This meeting is being hosted by Geuder in collaboration with the DMEK Eye Bank Foundation in Venice, Italy. Allow me to introduce our first speaker, Dr. Diego Ponzin. Dr. Ponzin received his medical degree from the University of Padova and is currently serving as a medical director and cornea consultant at the DMEK Eye Bank Foundation in Italy. His area of research interests are eye banking, selective keratoplasty procedures, epithelial and endothelial regenerative medicine. It has been a wonderful journey working with him for almost a decade now, and I could have not asked for a better mentor than him. It is my great pleasure to welcome Dr. Ponzin to give the warm welcome note to every one of you. Over to you, Dr. Ponzin.
Hello, good evening, everybody. It's my pleasure to welcome to the DMEK world tonight. Descemet membrane endothelial keratoplasty is a procedure that can be defined extraordinary in terms of selectivity and visual rehabilitation result. At the same time, it can be defined a challenging procedure, either intraoperatively and in terms of follow-up, patient follow-up. For this reason, we regard with much consideration any initiative that is aimed at standardizing and improving either the donor procedure related to the surgery or the surgical procedure. And we have been very glad in this context to cooperate with the Geuder company that offered us the possibility to validate and made some preclinical and clinical validation on, of their new tool. That, as you can see in the following presentation, is an innovative way to hold, to transport, and to deliver the delicate DMEK tissue inside the recipient eye. So for this reason, I'm very honored to welcome the speaker that will follow my greetings. And again, I thank the Geuder company and also my passionate staff who contributed to this enterprise, in particular, Dr. Gabriela Wojcik, that is the leader scientist at the foundation involved in this project. I think that I have no more to say at this time, and I pass the testimony again to Dr. Mohit Parekh. Mohit has joined our group, as he said, more or less 10 years ago. He is a passionate and volcanic scientist. He was involved since the very beginning in validation and exploitation of new eye banking and surgical techniques on endothelial keratoplasty. And so I think that his contribution will be welcomed by all the audience. Thank you very much, and I hope you will enjoy the webinar.
Thank you, Dr. Ponzin. I'll take the first presentation tonight. I'll just take the audience towards a journey where we started the preloaded DMEK. That was almost probably about 5 years ago, 5 to 6 years ago, when we started exploiting the preloaded DMEK story. I don't have any potential conflicts of interest. In terms of preloaded DMEK, where it all started. So basically, when we were exploiting the loading of the endothelial keratoplasty tissues, we started with the pre-cut tissues at the DMEK Eye Bank Foundation, and then we jumped to preloading the tissues in the smart storage glide, which was all 3D made and 3D printed, and we also did a lab and clinical validation for such devices. And more or less, the lab and the clinical study showed similar results as the conventional DSEK techniques. The idea behind the preloading of DMEK with the endothelium inwards, especially, was basically to understand whether the tissues actually flap out automatically inside the recipient eye, similar to what we see in the DSEK tissues. So once the DSEK tissues is stored in a glide, once it's removed and transplanted inside the recipient eye, we usually see that the flap opens up very easily. And this was the whole idea behind the endothelium inwards DMEK preloaded technique. So what we did was to rather peel the DMEK tissue and put it in PBS, and then allow the tissue to roll it outwards with the endothelium outwards automatically. Instead of that, we rather manually folded the tissue on the cornea itself, like a taco. So we like two flaps and overlapping each other, and then added both of them. So basically, the whole taco fold was then gently loaded on an IOL cartridge. This was the very first prototype that we were using for the preloaded DMEK. And this taco was actually then loaded on the IOL cartridge and then pulled inside the funnel of the IOL cartridge. And this funnel, the diameter of the funnel was almost exact that we wanted to maintain the architecture of the endothelial graft. And this taco fold was then maintained inside the funnel of the cartridge, where we also added transport media, which is a preservation media for the endothelial cells. And we blocked this entire device from both the ends, from the rear and the front, and we preserved it in the transport media. What we found in the laboratory setting was that the stripping and the loading time was about 20 to 25 minutes. And the ECL post-preservation was about 4.35%, with the uncovered areas reaching up to 8%. And this was our first endothelium inwards preloaded tissue publication back in 2016. Followed by which we also compared the endothelium inwards and the endothelium outwards method. And what we found was that the loading time with the endothelium inwards method was significantly higher compared to the endothelium outwards method. This is basically because the endothelium inwards method requires manual maneuvers and a loading of the graft, compared to the endo out method where the tissue is almost ready and you just need to aspirate it inside the modified Jones cube or any other cartridges. However, the time to unfold the graft inside the recipient eye was significantly lower with the endothelium inwards method, because the graft opens up automatically inside the recipient eye, compared to the endo out method where you have to play with the tissue inside the eye to attach to the stroma. We also ran the preloaded DMEK clinical study using the same cartridge. And this was performed by Professor Massimo Buzzin in Italy. And this was the first one with a preloaded endothelium inwards. We found that the preparation time was about 26 minutes, with surgical time less than 9 minutes. The BSCVA and the endothelial cell loss was comparable with the conventional DMEK clinical outcomes. This is a very quick video to show the actual functioning of the endothelium inwards method. So once the device is inside the recipient eye using the microincision forceps, it's just the graft is actually delivered inside the eye. It's just pulled inside the eye. Pull through technique allows a full control of the graft inside the eye. And once it's pulled inside the eye, it just needs a gentle tapping on the surface of the eye, and this basically opens up the whole tissue. So this does not require a lot of maneuvers inside the eye. So basically, the whole tissue can be grafted within less than 9 minutes, as we have already found. Just an air tamponade to attach the graft to the stroma, and a very nice grafting was completed. Also, over here, we also found that the F mark was visible at about 3 months, but it fades off with time. Sometimes we don't get F mark even after 1 day or 2 days. So that completely depends. In terms of endothelium outwards method, it's already been visualized and analyzed. The endothelium outward method is already being used in the United States, and we have found that the ECL is almost similar to the other endothelium inwards and outward method, and it also shows a similar clinical outcomes as compared to the conventional DMEK transplants. This is the preloadable device that we'll be talking about today, and this is the one that's coming from the Geuder for the preloading. Preloaded DMEK has been shown to be massively taken up by many eye banks, and a lot of publications have come in very quickly in the last 5 years, and we are hoping that this will be the next game changer. So the take-home message is that the preloading DMEK, both endo in and endo out, is very easy to use. It's time-saving. It's hassle-free for both the clinicians and the patients sometimes. The clinical outcomes are similar to the surgeon-prepared DMEK grafts, and the endo in and endo out both have shown similar clinical outcomes. Whether it is cost-effective or not still needs to be evaluated, and this is something that is ongoing. I thank all my collaborators at the Venice Eye Bank Foundation, Geuder, UCL, Institute of Ophthalmology, MOFIS, and Royal Liverpool University Hospitals. And thank you for your kind attention. Without wasting any further time, I'll just go on to our next speaker. That's Professor Szurman. Professor Szurman is an ophthalmologist, scientist, and the director of the Eye Clinic in Sulzbach at the Knappschaft Clinic Saar in Germany. His key interests are in the development of new surgical techniques that includes biotechnological and biomedical tissue replacement, both in retinal and corneal surgery, and stem cell therapy. Prof. Szurman holds several international patents, including the Geuder DMEK glass cartridge and DMEK Rapid, that have contributed to the development of the DMEK transplantation. I'll hand it over to you, Dr. Szurman.
Thank you very much for the nice introduction, and good afternoon. So just a few words on the working principle and handling of the preloaded DMEK. You have heard 13 years of DMEK, and we have you get used to it that it's a 5-minute procedure. Next, please. But in fact, it has been a long way with multiple evaluations of several groups worldwide. I just show you for 2 minutes most important milestones. The next. The first was the no-touch technique with the first cartridge to inject. Before we had only an IOL cartridge, and this is a glass cartridge which allows the visual control of the perfect orientation. On the left side, you have the preoperative situation with a stained DMEK lamella ready to inject. The second was the liquid bubble technique, which we have presented in 2014. It's published and it works. Unfortunately, all the videos are not active in this presentation. With this liquid bubble technique, we have the possibility to prepare the DMEK lamella within 2 minutes by injecting in the sub-Descemet space trypan blue. With a 99% success rate, and the advantage is that we have a staining only on the Descemet surface of the DMEK, so the endothelial, the delicate endothelial cells are not in contact with the dye. In 2015, we have professionalized by preparing all DMEK cartridge in the clean room tissue bank. The next, please. Personally, I think that it's very important to give an example that the tissue is prepared under highest quality situations. It is European law, and this will be the future for all eye banks in the near future. In 2016, we have introduced together with Geuder the pre-cut tissue with Geuder and the DGFG. Next, please. The idea behind, and you have also mentioned it before, is to separate the implantation from the preparation. I'm absolutely convinced that the DMEK implantation can be easily learned by an experienced anterior segment surgeon, so not necessarily by a corneal surgeon, but the preparation is still a problem and bears some risk if you have a tearing, and it's much better to outsource it in the tissue bank where experienced medical doctors or even technicians do the preparation. If they do 5 or 10 preparations per day, then they are even better than me as a corneal surgeon. So this was the idea behind that the preparation is done separately, and the surgeon gets a ready-to-use lamella, and he can load the Geuder cartridge with it and then implant it. Next, please. In Germany, we have only 2 eye banks which are allowed to deliver this pre-cut tissue, Sulzbach and Hanover. Next, please, where it's prepared under highest quality conditions. And we have currently 2 techniques. Hanover uses the LAMEC technique, which is a manual stripping with a centrally adherent part. So it does not swim away. And in Sulzbach, we prepare it with a liquid bubble technique. Next, please. So, and now we are, of course, proud, and that's why we are sitting here, to present the preloaded DMEK cartridge, so the DMEK Rapid. And the idea behind was to preload it in a Geuder cartridge, which is similar to the standard injection cartridge. This transport cartridge is about 50% of volume bigger than the normal Geuder cartridge for injection. So it can be loaded and transported, but the surgeon can take it and inject the DMEK directly from the transport cartridge. The next, please. That's how it's delivered. So on the right, you see the blue-stained DMEK, which is already preloaded in the cartridge. On the left, you see the pre-stained DMEK roll. And if the surgeon receives this preloaded cartridge, it's very easy to restain it if it's necessary, because it's closed, but there is a ventile and you can inject trypan blue, and the DMEK still stays within the transport cartridge, within the DMEK Rapid. And then you can inject BSS, and so it's diluted again. Next, please. And then the surgeon just puts a syringe to it, and it's ready to inject like you like. We've done a study. There are currently several studies in every country. So it's in Germany, it's already approved. We have shown that the DMEK Rapid is as safe as a viewing chamber. We had a prospective study with 2 groups, viewing chamber versus DMEK Rapid. Next, please. And yeah, the result is quite easy. Neither in the viewing chamber, next please, nor in the DMEK Rapid cartridge, there was a significant cell loss within 5 days. Next, please. So it's approved and can be delivered, but every country has asked their own official departments for official approval. The good idea is that if it's prepared with a liquid bubble technique, then the staining, the blue staining of the DMEK lasts for about 2 days. So normally it's delivered to the surgeon already pre-stained. If it's not enough, you can restain it, but in many cases it's even enough to just take it without restaining, and you can see the blue contours. The next, please. So it's approved since 2019. It's ready to inject, and it's called and marketed as DMEK Rapid. And of course, I'm very proud about the good work of Geuder, who have done an excellent job to deliver a high quality product as a ready-to-use product. A cataract surgeon is used to use a preloaded IOL cartridge, and it's a quite natural step to deliver now a ready-to-use preloaded DMEK Rapid cartridge for DMEK surgery. Next, please. That's a preloaded DMEK. Next. And that's what we are doing now. Then the next. You can look for the video. It's on our YouTube channel. If you just Google YouTube Sulzbach, then you find it. It's a live surgery of the first preloaded DMEK with a DMEK Rapid. And next, please. These are the videos we skip. Next, you can see it on the YouTube channel. Next. And if you are interested, we have in April a DMEK intensive course where you can learn the DMEK technique in a wet lab course. And next, and that's it, I think. Thank you very much.
Okay, so I'll quickly jump to our next speaker. That's Ms. Gabriela Wojcik. As Dr. Diego Ponzin said, she's a driving force behind the preloaded DMEK Rapid in collaboration with Geuder with FBOV. She's basically a research assistant at the Venice Eye Bank Foundation with a bachelor's degree in biology, specialization in cell biology at Jagiellonian University at Krakow, Poland. And her research focus is on DMEK surgery, innovations, and human corneal endothelial cell culture. Over to you.
So, good afternoon. My name is Gabriela Wojcik, and I'm a researcher in Fondazione Banca delle Occhi in Venice, in Italy. I have no commercial interest to disclosure. I will tell you a little bit about validation we done with the aided DMEK Rapid system, and also update you on the clinical study we are currently on. Recently, we published the rapid validation results on the Cornea magazine. We divided our rapid validation in two parts. Study A, which was the in-laboratory 4-day transport simulation in the room temperature on the laboratory rockets with two different media types, tissue culture media and transport media. And the second part, study B, was the cross-country transport done in 72 hours when we preloaded our tissue in Italy and sent them to UK to be analyzed. We used the transport media for that. In our in-laboratory 4-day transport simulations, we noticed after the injections from DMEK Rapid, during the trypan blue staining, a little number of trypan blue positive cells. Our ECL analysis show the 14% on tissue after transport simulations of ECL in tissue culture media compared to 11.5% of in transport media. Analyzing red staining showed the little tissue scattering. Like that immunostaining showed the high presence of the culturing AM positive cells and low percentage of the endothelium homodimer percentage cells, so suggesting that DMEK Rapid system preserved the tissue. We also noticed the presence of zonula occurrence on our both media types, which proved to us that the DMEK Rapid system protects the morphology of the tissue. Like that analysis showed that in tissue culture media, there was the 79% of the viability of the cells compared to 81% in tissue in transport media. That result was not statistically significant, but we decided to proceed with transport media in our study B. In our cross-country transport, we noticed that there were little tissue scattering and trypan blue positive cells, but all orientated in the edges of the tissue, which suggests that it happens because of the force of manipulation. Alizarin red staining showed no tissue scattering. Like that immunostaining showed the high levels of culturing and AM positive cells. We also detect the presence of zonula occurrence. Our like that analysis show us that the tissue had around 85% of cell viability, and ECL after transport was 3 and a little bit more than 3%. Data results and the overall design of the DMEK Rapid system make us believe that this device is great for eye banks to provide high quality tissue right after the surgeon's surgical theaters. Our clinical study, we work with 5 centers in Italy and UK with 5 surgeons, and each of them have different endo-out surgery experience. The surgeons recruit for us 25 patients suffering from foot dystrophy. Currently, for today, 4 surgeons done 12 surgeries, both in Italy and UK. We have some preliminary results from one patient, from Dr. Pieplau, and you can see on the middle picture the F mark just after surgery, and how the clean cornea look after 1 month after surgery. The pachymetry and optical coherence topography showed there's a visible difference on the thickness of the tissue, suggesting that the graft works properly. Dr. Geuder Romano provided us with the results after 1 week after surgery, also showing very similar results with very clean cornea, and the pachymetry and optical coherence tomography suggesting also that the tissue is thinner and the graft works properly. I'm going to show you the surgery video done by the Dr. Geuder Romano. The surgeon is taking the holder with the Geuder device, introduce it on top of it. Everything is transported in these little bottles, which are standard bottles for the tissue banking. Tissues are introduced to the cartilages, which is the rear part, which is the shorter part, and the frontal part, which is the longer. Both parts have to be introduced to the device to make sure that the tissue is going to stay inside. The device is designed in the way that you can see the mark if you are requested to have it on the tissue. Overall, surgeon is able to stain the tissue and wash it inside the device without any problem. Here, surgeon is staining it by trypan blue and it's going to be washed by the salt solutions. The whole procedure is standardized, but it requires the learning curve. However, all the surgeons we are working with reported that the process is easy to learn. Here the tissue is on the frontal part of the device, so it's probably going to be easier for the surgeon to introduce it to the anterior chamber. Surgeon is unplugging the rear part of the device. And that's the place when he's gonna introduce the syringe and directly introduce the device into the patient eye. After introducing, surgeon is unrolling the tissue and putting the one bubble of the air to make it sure of the attachments of the tissue. Thank you.
I'll move on to our next speaker, Professor Vincenzo Scorcia. Professor Scorcia received his master's degree from the University La Sapienza of Rome, and is currently head of ophthalmology department of the University of Magna Grecia in Catanzaro, Italy. He completed a cornea and external disease fellowship with Professor Massimo Buzin based in Italy. His area of clinical practice are cornea, cataract and refractive surgery, with interest in cataract and refractive surgery research and lamellar and endothelial keratoplasty research. Over to you, Professor Scorcia.
Thank you, Mohit. I would like to thank Geuder and Veneto for Eye Foundation for the support. There is my financial disclosure. I do not have any financial interest to disclose related to this presentation. Next. This is my first surgery with the preloaded DMEK graft. This is a patient with Fuchs endothelial dystrophy. I mark the epithelial surface to choose the proper sites where the Descemet has to be removed. And I usually prefer to remove the Descemet with continuous air fluid coming from the machine because it takes the anterior chamber firm. This is how the grafts come in directly in theater. You can see the F. I usually wash the transportation liquid in order to remove the dextran, and I stain with ribbon because there is not much stain with the graft. And after that, I check for the F sign mark in order to select the proper orientation. I put the graft on bright contrast, usually white contrast, in order to check the orientation. And this is the surgery. I inject very slowly in order to avoid misdirection of the graft. But before remove the injector, I simply tap on the wound in order to release some aqueous, thus preventing the graft from escaping from the anterior chamber. And now it comes the most challenging part. I use the double channel cannula technique. So with one cannula, I keep the graft firm, and with the other, I tap the anterior corneal surface in order to unfold the graft. We need to remove some aqueous from anterior chamber because it works very nice if you keep the anterior chamber shallow. So you have to repeat this maneuver several times. And if you are lucky, it takes a few minutes to complete the graft unfolding. Once you obtain the unfolding, you have to put the cannula behind the graft, and you have to fill the anterior chamber with air. I do not put any stitches if there is no leakage from the wound, so I can leave the eye in this way. Next. So, since my first surgery, I found the injector very easy and safe to use, but the staining of the graft inside the injector may be less effective, but multiple staining could be safely attempted. The difference is because you stain the graft underwater, and they are less effective than you do it under air. So there is a big difference. But there is no problem because it's possible to stain several times the graft. Next slide, please. The small size of opening allows small corneal incision, and this is a big advantage because using small incision, you reduce the risk of graft escaping from the anterior chamber. But on the other side, can you back, please? On the other side, smaller diameter of injector increase the risk of raw configuration of the graft. Next. This is the video showing what I said before. This is a different patients, and as soon as I inject the graft in the anterior chamber, it was very, very narrow. So it's not very easy to open this graft because the roll is very close. And you need a lot of patience and experience in order to unfold this graft. You can use different technique, the double cannula technique. You can also use the cannula with the holes and the side because you can inject fluid from the side, but it's not very easy. And if you are not lucky, it may require several minutes, 10, 20 minutes, until you have found you can unfold completely the graft. Here, this is the last part of the surgery. It took 15-20 minutes until I achieved the unfolding, and after I fill the eye with hair. Next, please. So the time for donor stripping and preparation is saved. Also, the risk of tissue evasage is virtually eliminated. This is a big advantage. And so the consequence is that surgical times is reduced in almost all cases. However, the unfolding maneuvers remain the only unpredictable issue. Next, please. So the graft comes in theater with the hand-out configuration, and in this way the graft manipulation during graft loading is reduced, and the end-out configuration is the most preferred configuration from the surgeon. But on the other side, the endo-in configuration, sorry, there is a mistake, this is the endo-in configuration, may prevent a cell damage from injector, even if the damage is very minimal. But the endo-in configuration may reduce also the unfolding time, because as soon as you introduce the graft in the arterial chamber, it tends to recover its original shape. Next, please. These are our results. We perform preloaded DMEK in 6 eyes, and we recorded the surgical times reduced in all cases. The endothelial cell loss was comparable with previous technique, even if our follow-up is limited only to 1 month post-operative. Next slide. We need to rebubble 2 of 6 patients, but the bubbling rate was not different from the other conventional technique, and no other complications were recorded. Next, please. So, our tricks. We advise to carefully wash the transportation liquid, because the dextran in the liquid may behave like a glue in the anterior chamber. So it's better to completely remove the dextran from the graft. I recommended to stain several times the graft. Usually twice is more than enough to obtain a good staining. And we have to check the mark and accordingly rotate the injector before inject the graft in the anterior chamber, because doing in this way and injecting slowly the graft, you may prevent the graft upside down position. However, even doing this way, you always run the risk of graft upside down. Next, please. This was what happened in this video. I was very happy because I inject very slowly, and I was able to open the graft in a few seconds, but as soon as I opened the graft, I saw the mark was upside down, so I needed to change orientation. And what I can do is to grab the tissue from one side with the forceps. I open the irrigation from one side, and if you are lucky, it requires a few seconds to rotate the graft and to obtain a proper position. So the surgery was completed with hair. You can check for good position. I think it's done. Thank you. I don't know if there is any question.
Thank you, Professor Scorcia. That was a very brief clinical experience and insights on this new device. Let me quickly go to our next speaker, Mr. Tim Pieplau. Mr. Pieplau has a Master's of Science in Business and has held various positions in medical industries and business development and sales. Since 2017, he's also area sales manager at Geuder and director of Geuder Asia Pacific. Over to you, Mr. Pieplau.
Thank you, and thank you, everyone. It's a great pleasure to have over 130 participants here tonight. And we thank, of course, from manufacturer side, all our great partners throughout the past months and the past years. It's been a great pleasure working with you, Professor Szurman, for over a decade now about the DMEK. And we are very, very happy to have such great partners for the DMEK Rapid on board now in Europe, which of course namely is the FBOV and Mestre, around the team of Diego Ponzin and Gabriela, and also Dr. Ferrari is probably on the line today. We are very proud to call UCLA with Mohit, our partner, and of course also Dr. Romano from Liverpool and Dr. Rahman and Dr. Ahmad from Moorfields. So it's a very international collaboration. And we are also partnering here in Germany with the German Tissue Transplantation Society. So it's a great journey so far. And we really see that 13 years have paid off, right? Yesterday, we put the beetles here. We had the process of very tedious preparation in the OT itself. This costs a lot of time, and we've seen multiple times today now, and we heard it a lot from you. Thank you, the faculty, that preloaded will be the future. Yeah, we can start today. And as Dr. Ponzin said, very high efficiency and efficacy in the DMEK procedure can be secured by the preloaded. We do have consistent validation and very promising eye bank and surgical results. And as Dr. Parekh pointed out, endo in and endo out both work very well. And we hope that everyone is convinced that the DMEK cartridge is working very well. And we encourage you to try out this method, of course. As Professor Szurman pointed out, the no-touch technique, that's a very big advantage. Everything of the preparation is taking place at the eye bank. And this is what also our clinical studies and our validations have shown so far. So the future will be the preloaded. The benefits, of course, they vary greatly. As Gabriela has pointed out from the eye bank side, in our validation, we found that there is a very minimal cell loss that can be attributed to the transportation process itself. Most of the cell loss is attributed to the preparation, and we will always occur this loss. Now that we are in the clinical study across the nations with 5 surgeons and 25 patients coming up, we will hope to have more positive results coming soon, and that the surgeons can be supported with high quality, ready-to-use grafts. Professor Scorcia, he pointed out very well all the benefits for the surgeons tonight. And of course, we are very pleased to hear that the risk for tissue wasted is virtually eliminated. So again, the time is saved. You have an added security in the OR, and you can more reliably plan your OT procedures. And in between the cataract surgeries, you can easily fit in a DMEK surgery by the tool of the DMEK Rapid. In the end, it should be an easy implementation into your standardized workflow. And also, he pointed out a few pearls and tricks. For example, that the injection of the graft should happen slowly, and that staining before was not a problem. And as the take-home messages tonight, we would encourage everyone to contact your tissue banks now and ask for the preloaded DMEK Rapid, and of course also to seize the various possibilities in the community, get in touch with your senior ophthalmology surgeon comrades, and participate in wet labs if you have the chance. For example, with Professor Szurman in April next year, or also at the conferences, which we hope will be coming up next year or in 2020 at the very latest. In the end, be an early adopter and enjoy the advantages of the preloaded DMEK. And with this, I would like to hand back to Mohit, because now we would like to enter into the Q&A session, and we kindly ask you to submit your questions by using the Q&A button, and then we as the panelists, we will take up your questions and provide the answers.
Okay, thank you to all the speakers tonight. It was really a great insight to the new device and the whole preloading area that we are working on, including the clinical results and the clinical outcomes, and also the laboratory investigation, the cross-country validation. So it looks like we are going towards a completely different route now, from PK to pre-stripped DMEK, and now just jumping over to the preloaded DMEK, both with the endothelium in and endothelium out of this method. So, well, we have received a few questions, and some really interesting questions, and some of them which are usually asked to a lot of eye banking personnel. So I think I should really ask this question to Dr. Ponzin. How do we really ensure that the marking stays in? That is regarding the F or the S mark that we put to figure out the orientation of the graft. And if the marking is lost, then is there a way that we could figure out the orientation once the tissue is already inside the recipient eye? So to Professor Szurman, Dr. Ponzin, Professor Scorcia, you might want to comment on that.
I think there is not really a chance to do an F or an S. We use a shark marking, which means it's also published by another group, and we use it since 3 years. A small shark tooth is cut to the edge of the DMEK lamella. And by staining the lamella, you can perfectly see the orientation. And that's what every DMEK preparing eye bank should do, as far as I recommend.
I agree with this comment.
I agree too. It's very rare to lose the mark in DMEK configuration because the stain is very strong. It lasts several weeks after, or even months after surgery. So it never happened to me. So I can say nothing of different.
Well, that's actually very true, because we have seen the staining even after 3 months and all the way up to 6 months in some patients, and it fades off with time. So that could easily be taken care of. The other one of the very important questions that a lot of attendees have been asking is how do we ensure the microbiological issues for preloaded DMEK? So once the tissue is already inside the cartridge and once we ship them, how do we ensure that the tissues are going to be safe when you transplant them?
What do you mean with safe? I didn't understand.
So for all the other tissues, what we usually do is we have the microbiological checks before we ship the tissues. But for the preloaded tissue, it is going to be in another device with the media in. So exactly before the transplantation, how do we ensure that the tissue is safe in terms of microbiology and it's not contaminated, basically?
Yeah. So every preloaded DMEK which leaves the tissue bank gets a microbiological testing before. It's a legal issue in Germany. It's not allowed to transport it, to ship it without this microbiological testing. So to my opinion, it's the highest quality that even after preparation, we have a microbiological testing.
Professor Szurman, the question was even more specific. The colleagues from the Netherlands were asking that in the standard before we started with preloading, there was, according to their information in the PI regulation in Germany, that you should perform a culture test after storage and another one after preparation, and then you would ship. And the question was if we could lose this, or if we test then in preloading just before implantation, or how do we still fulfill those PI requirements while we now apply preloaded and we miss one step?
Yes, so I'm not sure how to answer. You have the medium, you can always take a probe from that and do an additional testing if you like.
That's what I exactly thought, that you maintain the storage medium, so at any time you could apply the storage medium for doing tests.
Yes. I mean, it's important question. The quality control and the high standard of preparation in a standardized manner is certainly one of the main advantages of these standardized technique. I think although many surgeons are experienced, we have no control what happens during preparation and directly after preparation. During the time in the tissue bank, everything is standardized. For every step there is legal quality control, but once the surgeon starts to prepare, we have no legal quality control. And here we have just an improvement in this quality control, to my opinion.
Good. Despite some questions whether the device itself is suitable for hypothermic solutions, yes, it is. It's used in the United States for cold storage, like it is used in Europe for warm storage. Many questions were related to the handling and how easy it is to wash out the storage solution, how easy it is to apply staining inside the cartridge without moving the lamella. Maybe some of the colleagues who have been more frequently using it in EOR might answer that question. Maybe either Mohit or maybe Professor Vincenzo might answer this question.
So for the cross-country validation study, when we performed, so all the tissues were loaded in the eye bank in Venice, and it came to us for the validation over here in UK, and it was pretty easy. Basically, the device has two lids. So there's one chamber that fits on the anterior and the other one on the posterior, and these both lids have got pores inside. And pores are so small that it can only allow the liquid to flow out when you pressurize the liquid, but it does not allow the tissue itself to go out of the device. So when you fit the tube in and you start aspirating PBS, the tissue, you can actually see the tissue that's rolling inside the device, but it doesn't really let the tissue out of the device. So you can remove all the media from the device. You can wash the tissues. You can stain the tissues inside the device if needed. So I mean, yes, it's relatively it's very easy because it does not allow the tissue to go out. So you can play in your field basically. So you can just wash it and do whatever you want to inside the device. I purposely I pushed in a lot of liquid just to see whether there is a lot of endothelial cell damage, and honestly, I mean, it wasn't really a huge endothelial cell damage that was observed, because the tissue it actually flows with the liquid itself. So it kind of opens and shuts, and that's all we have observed. So in terms of washing the tissue or restaining the tissue, removing the liquid from the device, it's pretty easy.
Yes, Mohit, if I can add something, I think I agree with you, because there is no way for the graft to come out from the injector, even if you force the fluid injection. But if you said, if you force the BSS injection, you run the risk to crash the tissue against the wall. I don't know how many damage you can induce, but there is no reason to force injection, because you can simply wash by keeping the graft floating in the middle of the injector. So there is you don't have to inject too much BSS, because you can see the graft floating, and this way you can remove all the dextran from the injector.
Yeah. So this was basically when we inject it, when we infuse a lot of pressure, it was just to validate whether increased pressure can damage the endothelial cells or not. But yeah, it just works well. It didn't really induce a lot of endothelial. There are other questions coming up in terms of graft, again, the marking. So if you can if we can have like a shark tooth marking, or F or S, or with stain, without stain. So Dr. Ponzin, do you want to add on the marking scheme or something?
Well, I just confirm what has been said before. I mean, marking is done in the eye bank, and it's very. I don't see possibilities to repeat marking once the thin DMEK lamella has been isolated and moved out of the cornea. So I think that if the surgeon go thoroughly and slowly while inserting the tissue in the anterior chamber, as Vincenzo Scorcia pointed out, I think it will be not necessary to have the mark done again.
And then there are some questions coming in about the availability of the device in the UK, and also about the costs of the device. I mean, maybe
I could not hear the question. Please, can you repeat it?
Oh, it's about the DMEK Rapid availability in the UK. Whether they are allowed to import, or whether you can use it with hypothermic media and an organ culture both. So I think to answer that, we already have two different devices. I mean, it's the same device, but with the two different flasks, and one is made for the hypothermic media, and the other one is for the organ culture.
Yeah.
Well, the devices are readily available. It's just a matter of the eye bank, whether they want to, eye bank and the surgeons, whether they want to ask for the preloaded tissues in the Geuder device. So this is where we are. I think we've almost covered up almost all the questions, and I think we can kind of wrap now. So.
Yes, Mohit, we are like 5 minutes over the time. It's really difficult to capture then all the questions which are coming up in writing. Yeah. But I invite cordially everybody who was there and didn't get his question perfectly answered to drop us a message, and then we will follow up offline as good as we can. Nobody will left without an answer. Thank you very much to the panelists as well as to the audience. It was highly appreciated. And I wish you all an enjoyable and relaxed ending of that day.
Thank you very much. Thank you.
Thank you, everybody. Good night.
Thank you, all the audience.
Thank you, everybody.
Grazie. Ciao.
Bye-bye.